right, we're going to go ahead and get started, everyone. Thank you for coming on this last day of the conference. I'm Chrissian from Loma Linda University. On behalf of my co-moderator, Dr. David Shaw from Harvard UCLA, we welcome you to this session, Essential Knowledge in IEP Series, Session 2. This is going to be Advanced Diagnostic Bronchoscopy, approach to non-malignant disease. So really briefly, for those of you not familiar with the Essential Knowledge in IEP Series, is a three-year cycle of sessions that we put on at the annual conference. And really the goal here is to provide core content and updates on evolving areas, new practices, and so forth. So for example, we initiated this 2 years ago with an update on pleural disease. Last year was therapeutic bronchoscopy. This year is advanced diagnostic bronchoscopy. And we actually completed our first session yesterday, which focused on the approach to malignant disease. And again, this is the second session, approach to non-malignant disease. We do encourage the involvement of fellows. So we do have 3 fellows here today that are going to be participating in the talks, and we leave it up to the faculty to introduce them during the talks as appropriate. So one final thing: this content is available on the AABIP website, and it's not just today's session or this year's session, but also previous sessions materials. So I encourage you all to go to the AABIP website to review that at your convenience. So this is our panel today. We have 3 great speakers. We're going to be guiding us through the content, and I think we'll all agree that malignant disease, when we're talking about within the context of advanced diagnostic bronchoscopy, gets most of the attention, and probably rightfully so. But non-malignant disease, of course, deserves quite a bit of consideration. First off, it's always on the differential. So important concepts that we're going to talk about today, things like leveraging non-invasive testing for more precise procedure planning, focusing on enhancing the yield of a specific non-malignant diagnosis for therapeutic planning, for example, what to do with that pesky non-malignant result. And then finally, evolving role of ADB for diffuse lung disease. These are going to be all concepts that we're going to be talking about today. All right, with that, I will introduce our first speaker. Dr. Abesh Niroula comes to us from Emory University. He's an interventional pulmonologist there, and he's going to be talking to us about how to leverage imaging and clinical insights for precise procedure planning. Dr. Niroula.
All right, thank you for the introduction, Mara. I have no disclosure pertinent to this talk, no conflicts. So the objective of this talk today will be to review 2 reasons why risk stratification is important. We will also review 3 specific ways to perform non-invasive risk stratification, where we will look at clinical models and radiological features, and review some serologies out there for fungal infections, and then currently available nodule markers. So very basic, we know that lung nodule is a burden. It comes with a lot of patient and provider anxiety. But we also know that a lot of these are benign lesions. Only 1 to 5% are malignant. So the etiologies of non-malignant causes can be different. Benign lesions like AVM, hematoma, and low-grade tumors, fibrosis, atelectasis. But I think depending upon the clinical context, especially with the chronicity of how these nodules can present, especially in immunocompetent versus immunocompromised patients, can occur in a whole host of infectious and non-infectious pattern. So stratifying them, not only to find malignant disease but also to classify benign is really important. And we know that we have guidelines and some models where very low risk nodules could be managed with just imaging surveillance, and the high risk nodules can proceed to definitive therapy with surgical excision. Unfortunately, most patients with nodules fall in the intermediate risk. And multiple options are available, including biopsy by bronchoscopy or TTNA, or continuing imaging surveillance, or even surgical resection. So how do we shrink this intermediate pool to a smaller level where we have more definitive answer to follow these treatment algorithms becomes very important. So the patient risk factors like smoking and history of lung disease are always important, and clinical risk stratification is the starting point. We know that nodule size is a primary determinant of cancer risk. The lower they are, the smaller chance that they are cancer. The larger they are, the increase in chance of them being cancer. The growth of the nodules by type and etiology is also really important. In this retrospective study, nodules were measured using semi-automated volumetric segmentation software where growth was defined as an increase in volume by 25%, and it is noteworthy that 68% of malignant nodules and 33% of benign nodules grew. So it is always important to confirm past imaging so that a growing and solidifying nodule is always suspicious for malignancy. However, we're characterizing this growth based on confounders, size, type, CT resolution, and interpreting clinicians with patient history is really important. We know that clinical risk models are important. The Swenson or Mayo models, Brock models, and VA models. Just raise of hand, how many audience do these risk models in every nodule? Yeah, so hopefully most of us do, and they're not perfect. So the basic approach to evaluation of the CT of these lung nodules are depending upon the nodule characteristics. How do they look, their density, shape, margins, internal characteristics like fat and calcification, and then some other complex findings. And we know these pictures very familiar, right? If a nodule is spiculated, irregular borders, upper lobe location, part solid density, and with other features like pleural retraction, pleural tags, or internal air components like bronchogram or cyst could be highly suspicious for malignancy. And then there are benign lesions, which are especially the periphyseal nodules, which are typical, that is not crossing the fissure, they are not looking spiculated, even if they are growing in size, they are most likely to be benign. The internal features of benign etiology like calcium, central calcifications, are mostly benign, and then we know that some of the malignant lesions could also have some different patterns of calcifications. And then there are some typical findings in CT scan where, if they have a comet tail sign where there's rounded atelectasis, or AVM, which has a feeder vessel, we should probably not biopsy them. Then there are lung cancer mimickers, endemic fungi and tuberculosis. They all manifest as pulmonary nodules, or they can also present as mass-like consolidations with thoracic adenopathy. And depending upon what type of these diseases are, the frequency of associated thoracic adenopathy can be different. And they may also have a geographical distribution. Taking example in cocci infection, in this study by Peterson and colleagues looking at the radiographic features to distinguish cocci versus lung cancer, they reported that cocci can present with mediastinal adenopathy, can also present in upper lobe with speculation, or can have smooth borders and have tendency to have satellite nodules. In the same study, they reported that presence of satellite nodules, cavitary component, and absence of chronic lung disease had high specificity and accuracy for diagnosis of cocci. In tuberculosis, in this study, which was done in a TB endemic area, benign etiology was clearly less likely if nodule had features of spiculated margin, pleural tag, and contrast enhancement, and node enlargement. In addition, cavitation and satellite lesions were more common in tuberculosis. Halo signs are helpful. They are always not reliable. It depends upon clinical context. They might be more helpful in patients with immunocompromised status, suggesting that there may be aspergillus. Similarly, in non-infectious inflammatory disease like GPA can present with nodules, ground glass, and consolidation and cavitation, and even speculation. So non-invasive testings have some role, and let's look at that in few of the endemic fungal infections that is in our differentials. For example, in cocci, antibody IgM and IgZ levels have reasonable sensitivity and specificity, but they do cross-react. And if there is a high suspicion of infection, even if the serologies are negative, we might have to consider retesting or even biopsy them. We're going to see this pattern in a lot of other fungal disease like blastomycosis. Although the antibody have high specificity and antigen also has high specificity, they can cross-react with histo. And again, if there is a high suspicion and negative serology, we do need to repeat testing and biopsy. And this is true for also histoplasmosis. This is very random. Has anybody seen a donkey eating food video by any chance? It's very soothing, by the way. That has nothing to do with our talk. Anyway, so continuing with non-invasive tools, Now we are trying to shrink this intermediate risk group, right? So, how do we enhance non-invasive risk stratification with biomarkers? And there have been imaging, blood, and respiratory biomarkers that have been looked at that. So let's talk about radiomics. As we all know, identification, extraction, quantification, and analysis of imaging features from radiological images that are beyond the capability of radiologists is what basically radiomics is. And in conventional radiomics, the nodules are segmented and are extracted, the information is extracted and analyzed. However, in deep learning with artificial neural networks, these extraction and analysis are hidden and only the output, for example, benign or cancer, is reported. This has been validated. Optilum lung cancer prediction module, which is the only US FDA-cleared radiomic tool, they looked at lung cancer prediction convolutional neural network, LCP-CNN, an AI-based computer-aided diagnosis model trained over 15,000 CT scans from the NLST group, was validated in North America and Europe. And what they found is the radiomics performed better than just clinical models like Brave, Mayo, and Brock. Now, there are other nodule markers that have been studied based on what are the different origins of these markers, what are we measuring, and what are the source, how are we sampling these biomarkers. There are a lot of protein-based markers that have been studied. This is a really good review paper published a couple of years ago in CHEST. If you want to look at that, discussing all of that is really beyond the scope of this talk today, but we will focus on currently available biomarkers. And these are mainly the blood-based biomarkers, the Notify. There are the Percepta genomic sequencing classifier, which is the airway-based biomarker, and then the LCP-CNN, the radiomics, which we talked about, and then the Reveal, which is another blood-based biomarker. So in a Panoptic trial, which was a study looking at assessment of plasma proteomics biomarkers' ability to distinguish benign versus malignant lung nodule, the authors studied classifier refined to two proteins, the LZ 3BP and C163A. This was a prospective multi-center observational study performed in 33 North American sites, and they looked at lung nodules 8 to 30 millimeters. And what they found was, the sensitivity was pretty high and it had a good negative predictive value. But the authors also reported in this paper that 32% of fewer invasive procedures would have been performed on benign nodules. This was followed up with a 2-year follow-up of the population, and they found that all nodules that were designated benign at 1 year remained benign by imaging at year 2. And this was not only true for solitary lung nodules, but there were also similar results, who had multiple nodules. This has been further studied to study the impact in real world. This was a retrospective study which kind of reported the similar outcomes, and the use of integrated classifier was associated with fewer invasive procedures and clinic visits. The Oracle study group wanted to go one step further. They did a prospective study on looking at if actually the procedures will be less. This was a propensity score matched cohort study where they compared prospective XL2 guided integrated classifier nodule management against a retrospective control population. It included the similar population like Panoptic trial, and they controlled for nodule size, speculation, and other parameters. And they found that in 197 patients in each group, where they looked at the primary outcome of difference in benign nodules undergoing invasive procedures, they reported that 5% of integrated classifier versus 19% in the control group of benign nodules underwent invasive procedures. That was a relative risk reduction of 74%. They also reported that 90% of patients with likely benign results reclassified to less than 5% category. So there are other blood-based biomarkers that have been studied. For example, MegaRA, this is a Reveal, that looked at 7 plasma and 6 clinical factors, and they kind of came up with a new risk model, which actually showed potential to improve peripheral nodule risk assessment as well. Let's move on to the airway classifiers. Bronchial genomic classifier Percepta was one of the airway classifiers that were measured in epithelial cells collected from normal appearing mainstem bronchus. This was published in NEJM. The classifier alone was, showed very high sensitivity and a high negative predictive value. In intermediate risk patients with a non-diagnostic bronchoscopy examination, a negative classifier score provided support for surveillance. And the impact of Percepta has been studied in a registry from 35 centers in 283 patients with non-diagnostic bronchoscopy. And the authors reported in this paper that the down classification of the nodule malignancy risk decreased additional invasive procedures without a delay in the diagnosis among those with lung cancer. There are other emerging biomarkers like microRNAs and liquid biopsies, which have not been really validated in intermediate risk population. Now, there are some other more studies coming up, looking at multimodal pattern now. For example, in this particular study, looking at IgG and IgM antibodies to histoplasma in 327 patients, where 157 of them were from histoplasmosis endemic regions. They found that the combined biomarker model, including radiomics, histoplasmosis serology, and Mayo score, improved diagnostic accuracy when endemic histoplasmosis was accounted compared with Mayo score. Similarly, there are other studies we have performed integration of this classifier with clinical protein and radiomics. For example, in the study by Kramer and group, where they looked at the integrated classifier, clinical criteria, protein and radiomics signature, they found that reducing the rate of unnecessary invasive procedures while shortening the time to diagnosis. So the future for biomarker, really, we need to have a model which reduce the time to diagnosis in patient with cancer without increasing procedures with benign nodules. And then we need to reduce the number of procedures in patient with benign nodules without delaying diagnosis in lung cancer. So in summary, practical approach to benign lesions, they need risk stratification before and beyond biopsy. We will use clinical, serology, and multimodal approach, and using guidelines plus models and patient factors are really very important. So that was my talk. Thank you. I'm going to introduce our fellow, Dr. Neeraj Gowda. He's our interventional pulmonary fellow at Emory University. He's going to present one of our cases that we recently had. Thank you so much.
Good morning, everyone. Like Dr. Niroula said, I'm the IP fellow at Emory. So this is actually a lady that we saw in IP clinic when I was a PCCM fellow. So this is an 84-year-old woman, a history of heart failure, preserved ejection fraction, hypertension, hyperlipidemia, history of a recent DVT-PE, and then group 2 PH. No tobacco use history, was actually referred to clinic for an incidentally discovered lung nodule that was noted on that DVT-PE scan. You can see she has this 2.1 centimeter nodule here. The most concerning finding was that she also was noted to have back pain during this admission and had multiple areas of compression fractures concerning for bony metastasis in her T12 to L1 regions. So after some convincing, she underwent a robotic bronchoscopy with sampling. Most concerning for a primary lung cancer, but ended up noting on a GMS stain of the biopsy specimen encapsulated yeast, which is consistent with cryptococcal disease. Turns out that we had gotten serologies after the fact because no one was really expecting any type of an infectious etiology for this patient, and her serum cryptococcal antigen was positive. She actually underwent 6 months of fluconazole therapy, not just for the pulmonary disease, but then also for the presumed involvement of her spine, and now is disease-free and doing pretty well.
All right, thank you. Thank you both. That was a super efficient discussion on a really, really complex topic. I mean, this probably could be its own course. I think we can all agree. So that was a great job in kind of fitting in. I think to summarize, rapidly evolving space, helpful in, we're talking about non-invasive testing, helpful in in helping us risk stratify benign from malignant, but not perfect, still a lot of performance gaps. And then sometimes it's helpful to know the diagnosis, the specific diagnosis, even in benign disease, which is a nice segue into our next talk. So I want to introduce Dr. Chenchen Zhang from University of Maryland. She's a practicing interventional pulmonologist there. And she's going to talk to us about the procedural approach for focal non-malignant disease and enhancing the efficiency of a specific diagnosis. Dr. Zhang.
Hi, everyone. I'm Chenchen. I'm from University of Maryland. I would first like to introduce my fellow so that he can present the cases. However, I do have to apologize that we don't have the slides ready for us to see, so he will just let you guys know about the story, and then he will tell you guys about the thinking process along the way.
Good morning, everyone. My name is Jonathan. I'm the current interventional pulmonary fellow at UCLA. And I'm going to try to keep this as interesting as I can without slides, so bear with me. But what I wanted to do this morning briefly is talk to you about two quick cases that kind of points out how the thinking process really does matter, specifically when we're talking about benign disease. So to start off, we have a 68-year-old female, history of RA-ILD on maintenance immunotherapy, with a known stable left lower lobe nodule, who now presents with a new left hilar mass with significant mediastinal and hilar lymphadenopathy that is very FDG avid on PET scan. Then you've got a different patient, a 70-year-old male with known history of malignancy, head and neck squamous cell carcinoma, with treatment of chemoradiation 2 years prior, who also presents now with a hilar mass with mediastinal and hilar lymphadenopathy. And so the question that I would pose is, what would you do with these patients? You know, how would you approach them in terms of your approach, knowing that one has a history of malignancy and it's higher in differential, and the other in which really no personal or family history of malignancy? What kind of tools are you going to use? Because you're probably going to want a biopsy. This is an IP conference after all. And, you know, are you going to want to use a needle, cryo, forceps, brush, all of the above? And that's kind of what we want to get at. And are you going to use ROSE, if ROSE is present at your institution? And what are you going to do if you get one of those non-specific atypical responses or simply benign lymphoid tissue? Are you going to follow up that patient, and what does that data look like? What we would have seen looking at the results is for that first patient with the RA-ILD, ended up getting all the things, a needle, cryo, forceps. The needle didn't give you anything in terms of granulomas, but it did end up showing evidence of histo. Your cryo actually gave you both non-necrotizing granuloma with histo, and your forceps unfortunately gave you nothing, just non-diagnostic. So this patient was sent to ID and was treated for pulmonary histoplasmosis, while the other patient, the patient with the cancer history, they simply underwent one modality, a 22-gauge sample of 4 lymph node stations, which all came back for non-necrotizing granuloma. So that patient was referred for sarcoidosis. And so what you have here are 2 different patients from 2 different institutions that obviously had different multimodal, well, one case, one modality for sampling, and the other multimodal. And the question is here, in benign disease, does that matter? You know, do we need to consider, do we just do the needle? Do we need to add cryo? Do we need to add forceps? Do we need to do all of it, especially when you're not getting maybe the feedback that you want from ROSE? And then, of course, what does the follow-up look like for a lot of these patients that have benign disease, and what's the data that's out there? So hopefully, after our presentation today, we'll have a little bit more information to answer some of those questions. Thank you.
Thank you, Jonathan. I feel like he deserves a round of applause. He did a really great job without the slides. I have to tell all of you that he did an amazing job with the slides, and it was very beautiful. Totally my fault. I forgot to put it in my slides. This is Dr. Jonathan Moniz. He's a current fellow at UCLA, if you guys are interested in recruiting him. Alrighty. So, hi again. I'm Chenchen, one of the interventional pulmonologists at University of Maryland. We're going to talk about procedure approach for focal non-malignant disease today. I have nothing to disclose, and we're going to talk about 2 things. One is pulmonary nodule, the other one is mediastinal lymphadenopathy. So when we're talking about pulmonary nodule, how do you define this is actually not a malignant nodule? It's actually not very easy, believe it or not. Oh, oops, sorry about that. So basically, you will need several criteria. For example, it's confirmed with a subsequent biopsy. you have to have a stability or resolution of the nodule on your follow-up CT scans. And then you may need a specific benign characteristics. You may want to have a positive microbiology results. And then a lot of times you may need a combination of some of them or all of them that mentioned above. In terms of pathology, it's suggestive but not diagnostic of malignancy when you see something like atypia or suspicious cells. This is also considered non-diagnostic. It is also suggestive but not diagnostic of some specific benign pathology such as non-specific inflammation. So when you see those things, you can't just like pat on the shoulder and be like, oh, I'm done. You're actually still in the mystery. And even if you have a specific pathological result, you may have a coexistent malignancy, so you may still be in trouble. So what do we do? You probably do have to follow up with imaging studies, but how do you follow up? How long do you follow up them for? 1 year, is that enough? 2 years? 5 years? Indefinitely? We just don't really have a great answer to that. So that's why we're going to talk about the diagnostic approaches that we're going to use, as well as what are we going to do after we do biopsy them. So the first thing I want to mention is the elephant in the room, because I feel like everyone is using robot these days. So what did the data show? As presented in some of the reports, if you read different reports, you may get a different diagnostic yield. Usually for robotic-assisted bronchoscopy, it comes all the way up to like in the high 80s range. And for the sort of like the older version with the ENB, we usually get to the 60s, 70s range. That's a typical number when we look into the literature. And then if it's a smaller nodule, they tend to be, the yield tends to be a little bit lower, and if it gets to 2 to 3 centimeters, the yield tends to be a little bit higher. And then the procedure time, it doesn't really make a whole lot of a difference. The pneumothorax, there was not a direct comparison, but the rate seems to be a little bit lower with robotic assisted bronchoscopy. And there are certainly built-in features when there is there are softwares to deal with the CT body divergence, and then it's very easy to use, and however, it does cost you a little bit more with the robotic bronchoscopy. So basically, great tool. You get a lot more diagnostics from the robotic bronchoscopy, but it does cost a little more money. And I feel like it's the same thing with cone beam CT. There is a really nice meta-analysis on it. And if you look into the data, when you use cone beam CT, you do get your diagnostic yield in the 70s range. And if you combine it with other things like radio e-buzz or navigation, and then you do get yourself in the diagnostic yield range of in the 80s, high 80s range. So that's really, really nice. And they have the cone beam CT combined with different things, with different diagnostic yield when you use different tools. Essentially, you get your diagnostic yield pretty high when you use those tools. This is probably what we see clinically as well. And then those are the two hot topics in the field nowadays, as I feel like everyone wants to get a robot and wants to get a cone beam CT in the hospital. That's why I touched a little bit on the diagnostic yield. I feel like if you guys have been to the malignant section, they do a pretty good job letting you guys know about the whole data on that. Now I want to talk about the tools that we use. For example, cryobiopsy. So for cryobiopsy, certainly very helpful, very easy to use, as you guys know, with your clinic practice. It does have an overall diagnostic yield of 92% for cryobiopsy in a paper that's published, and for the needle biopsy, it's relatively lower. And then let's dive into that paper and take a little bit more talk a little bit more in the true negatives and false negatives, because that's more relevant to our topic with a non-malignant pulmonary nodule. So if you take a look into that, with the cryobiopsy, with the true negatives, they do a little bit better, meaning that they tend to give you a higher yield when this is a benign disease. And then with the false negatives, for example, the initial biopsy did not show malignancy, and then with follow-up, you know this is malignancy. In the cryobiopsy group, you do see a lot less of those patients. Very nice. And this slides essentially showed very similar results. And then you can actually see in this paper, there was actually 18% of diagnoses that were made exclusively from cryobiopsy. Again, really nice tool, but it costs a little bit more. And then I want to touch a little bit on a specific topic with infection in all the benign diseases that we're dealing with. This is actually Dr. Era's paper. I want to mention that. And so in this paper, they actually suggested that with tissue biopsy, you do get a higher yield with infection, and then with the transbronchial needle aspiration and transbronchial biopsies, you do have a higher yield with the biopsy, not just a needle aspiration. And then with lymph node sampling and non-biopsy, they see most of the benefit in patient population with COXI. And then the same patient population, as you can see here, it's very interesting that the cytohistological diagnosis, it has an odds ratio of above 7. So that's really nice, meaning that you should not only send for culture, you should also send for pathology. That's going to help you as well. I believe we do that anyways. And so for mycobacteria, obviously, we definitely need to send that for culture. So very interesting topic as well. So now we talked about what we do after we do the biopsy. Okay, got it. Okay, got it. So for, thank you for that. And then for follow-ups, what we need to do. And then after you got the biopsy, and then you are seeing all kinds of reports from a pathologist about, this is no malignant cells were found. And then you're like, okay, what am I dealing with? This is true. How do I follow up? How often should I follow up? Should I rebiopsy? What do I need to do? Should I just empirically treat it? So that's a big topic in IP. I feel like we always kind of like stumble in that subject. And this is actually a paper that I did, so please welcome to read it. What I found out was that when you have different specific pathology report from the biopsy during your bronchoscopy, people tend to get a rebiopsy more often when they see language like atypical cells or suspicious cells. When they see that, they tend to have a short interval to get the rebiopsy. And that group is represented in in gray here. I'm colorblind today, my apologies. So in gray there, as you can see, that line is much higher than the other two. And then in terms of time to follow up CT scans, pretty much the very unique group is that when you see a specific pathology, for example, organizing pneumonia or granuloma, things along those lines, those people tend to get a repeat CT much, much later in the course of their disease. And then the other pathology, they tend to have a follow-up CT much earlier. So basically, I think what we know from this retrospective study would be that sometimes when you do your biopsy, you have different language from your pathologist that can help you to decide when I should rebiopsy and when I should do a follow-up CT scan. That may tour you a little bit. And then the next topic I want to talk about is on mediastinal lymphadenopathy. I feel like this is a topic probably we are more familiar with, and not a whole lot of brand new fancy tools that we can use nowadays, more of like the old stuff that we have already been using. For example, if you have suspicion of a benign disease, especially sarcoidosis, when you're doing your EBUS, then definitely thinking about the forceps, not just a needle biopsy. It does give you a little bit of a higher yield. And then for cryobiopsy, as you can see here in this paper, they actually found that if you combine cryobiopsy with needle, you actually get to the diagnostic yield range in the 93% range, which is really, really nice. And then if you take a look at the benign disease column, and it actually shows that there is a huge difference between needle alone versus needle plus cryobiopsy. Again, same conclusion. Cryobiopsy is your friend when it comes to EBUS to diagnose benign diseases. Same thing here. For the sake of time, I would just skip that. And then, then people may ask, oh, should I do both cryobiopsy and forceps biopsy? I have to be honest with you guys, before I encountered this paper, I never really thought about that, because I feel like either I'm just going to do cryobiopsy, I'm going to do forceps biopsy. I wouldn't really thinking about to do both. But some smart people thought about comparing them, which is really interesting. And then what they found was that, as you can see here, with needle plus forceps, the number is about 31, and then when they combine needle with cryo, the benign disease diagnosis becomes a 37 in their patient population. So the way that they did it is that they actually did needle, forceps, and cryo in all of their patients, and then they just take different data set to compare. So they have a total of 47 patients that were eventually diagnosed with benign disease. And then in the cryobiopsy group, they had a higher diagnostic yield for benign disease. But what I want to mention is that it's really, really interesting the way that they did the procedure, did the research, because they did 4 passes of needle and then 3 forceps biopsies. And then for cryobiopsy, they only took 1 bite, which is a little different from at least my clinical practice. I tend to do a little bit more than that. So I feel this is sort of like another summary of the complications from it. Looks like the cryobiopsy does have a little bit of a higher number. Again, this is a smaller study, so you have to take it with a grain of salt. All right. Again, I feel like all the studies have shown us cryo is really your friend. And then, does the needle size matter? I feel like this is probably a subject that we have encountered in the past already. In the benign diseases, I feel like we like a bigger needle. For example, here they favor the 22 gauge, and in another study, they did favor a 19 gauge needle. Another slide to show you, the bigger needle probably will give you a better yield in benign diseases. That would conclude my talk today, and thank you everyone for your attention.
Thank you to you both. Really good presentation, and I think highlights a lot of the same concepts that we see in malignant disease. Use more tools, diversify tools, and testing. For non-malignant as well. So that kind of makes it easy when we're approaching these patients that have kind of a undefined wide differential diagnosis. Okay, so for our final talk, we're going to actually shift gears a little bit away from focal disease and onto diffuse lung disease. So I want to introduce Dr. Sammar Alsunaid. Dr. Alsunaid comes to us from Montefiore. She's a practicing interventional pulmonologist there, and she's going to talk to us about some updates in advanced diagnostic bronchoscopy for ILD. Passing trend or a reliable chronic ally?
Hello, everyone. Thank you for inviting me to speak today. I appreciate the opportunity, and I would like to start by saying we have no disclosures and introducing my fellow who will be presenting a case to start off our talk. Dr. Jordan Friedman is one of our second-year pulmonary critical care fellows. He at Montefiore Einstein in New York and a future interventional pulmonologist.
Good morning, everyone. Thank you for having me. Thank you, Sammar, for the intro. So as we tend to do for these talks, we're going to start with a case just to sort of outline the topic. So a patient that we're going to discuss is a 53-year-old female. She has a history of Graves' disease, asthma, hyperlipidemia. She was initially seen in our fellows clinic in 2022 because she had 9 months of a chronic cough, essentially worsening dyspnea. She's like a Zumba dancer, workout kind of person. She couldn't do her exercising anymore. And in clinic, they walked her. She was sitting in the mid-80s on ambulation. She also had an abnormal CT, which brought her to our clinic. This is late 2022. She had no real relevant surgical history. Medications weren't particularly contributory. Family history, she had a history of lung issues on her father's side, but not really any clear sort of trend there. She grew up in the Dominican Republic, had biomass exposure as a child. They cooked with a wood-burning stove. She moved to the United States in the 80s. She's what most of us would consider a minimal smoker, 2 cigarettes a day over, a couple decades. And then she also noted in her kitchen some black mold spots that were there for around 5 years. She has a dusty apartment, 2 dogs, and a turtle at home. And when we saw her in clinic the very first time, she had a pretty extensive serologic workup for connective tissue disease and autoimmune disease. Everything was basically negative. We got pulmonary function testing in late 2022, which actually showed already severe restriction and severe diffusion impairment. And then this was her CT that was done right before she came to our clinic. The apices are relatively spared, but as you go down the lungs, you have a lot of reticulation, some traction bronchiectasis, and some early fibrosis. She ultimately was sent for a surgical lung biopsy, and the pathology showed NSIP. So what did we do next? We have a ILD board at Montefiore, and we sent her in to be reviewed by our multidisciplinary team, a team of pathologists, pulmonologists, radiologists, our surgeons, rheumatology, really everyone's involved in the care of these patients. And the feeling here was that she had fibrosing NSIP, possibly secondary to hypersensitivity pneumonitis from the mold in her kitchen. That was the best story we could get. And she was started on CellCept and followed up. A year later, we get another chest CT. The apices are still relatively spared, but as we go down, everything sort of looks worse. It's the same findings, but there's a lot more bronchiectasis, a lot more fibrosis, and she's a lot more dyspneic at this point. Her PFTs again show severe diffusion impairment and restriction, and so we discuss her case again. She's referred for double lung transplant, which she ends up getting actually 3 months ago, May 2025. She gets a double lung transplant, relatively normal hospital course. She had a post-op infection in the ICU and then eventually discharged. Here's her post-lung transplant CT. Now she has very good-looking lungs. Everything looks normal on her CT. And then she goes for, we haven't done full pulmonary function testing yet for her, but we've done post-transplant spirometry in the clinic. And now you can see, especially with her FVC and FEV1 trend on the right there, she's back in the normal range and she's feeling well. So this is just one example of a case with someone with ILD and how you might approach it. But I'm going to hand this over to Sammar to talk us through a little bit more about how we approach these, the tools we have, and who should we not biopsy, and how can we get better yield with our patients.
Thank you, Jordan. I would like to add that in addition to interventional pulmonology, I am a transplant pulmonologist, so this is my patient that I continue to follow this data, and she is doing great. So starting off, ILDs used to be known as diffuse parenchymal lung diseases based on ATS definition in the past. As you can tell, they're a group of heterogeneous diseases that have overlapping etiologies, overlapping symptoms, but really not always overlapping, with some distinguished features amongst them. As time has gone by, they've been lobbed into the definition of ILD, and you can see that you have at least 6 major categories of them with a lot of subdivisions in them, different causes, different disease patterns, and with that comes also different ways of treating them. There's a lot of overlap, but there's also a lot of differences that need to be distinguished so that you can give your patient the best chances. I came across this paper while I was preparing for this talk. So ILDs are also different worldwide. So if you're considering your next move, think you might be seeing a different variety of ILDs where you end up going. Before continuing into ILDs, there has been a statement paper by ADS that was published last month that distinguishes something called ILA, which is interstitial lung abnormality. This deals with the people that you find that had an incidental abnormal CAT scan. So they were getting a CT maybe for lung cancer screening, and all of a sudden you have some changes, interstitial changes, GGOs, and they have no symptoms. So what do you do with them? So they have their own category now. You are supposed to see them, screen them for symptoms, get a PFT, and test them for connective tissue diseases, check if they have family, but there's no indication to biopsy them or test any genetic testing, and you should follow them to make sure that they don't progress into a full ILD. So I thought that we should mention this before starting on. So as we mentioned, ILD, if you're able to identify the cause, great. If not, then you're going to be lumped up into what's called idiopathic. Idiopathic also has a lot under it. The most common ILD is IPF, and that one also has a little bit of variations under it. We've mentioned that they have similar but yet distinguishable features, similar but not always distinguishable features on imaging. As you can see, there's some overlap with what you see, but there's also certain differences that sometimes you're just not able to figure out what ILD they will fall under. So I'm stressing this point to see where you can help as an interventional pulmonologist biopsying these patients. So if you have the most common disease, IPF, and you have the most common presentation of it, which is a UIP pattern, usual interstitial pneumonia, then you have your diagnosis. There's no need to biopsy. Everyone can go home and you can start treatment. Unfortunately, there is a large group of IPF that don't have these distinguishable features, and they have maybe a probable or indeterminate or even something different. So after doing your history and physical, doing your due diligence, trying to figure out what's going on, looking at your images, your PFTs, the multidisciplinary team discussion is the most important part of this. And based on that, the decision would be whether to proceed with a biopsy or not. Biopsy is done mainly for the ruling out other causes, your differential, and then collecting the samples that will help you specifically be able to tell what's going on with this patient. So this paper is published in ATS from 2022 by Tomasetti and the group in Italy that specifically looks into why the biopsy part is very important. They had 426 patients that were referred to them for biopsying, and then what they did is that they all underwent biopsies, and they had their pathologist review the slides blindly with no clinical information. They had the radiologist review the imaging for these patients without any clinical information, put in what they thought the diagnosis was, and then they had the radiologist and the clinicians, pulmonologists review the images and the patients together and come up with what they thought was a diagnosis and how confident they were. And then finally they added the pathologist into the mix and had them review everything with the imaging to see how that impacted their decision. So what they found out was that they had about a third of patients that had a change based on looking at the tissue, whether it was reclassification into a different diagnosis, whether it was a change in the confidence of how you felt about what you thought they have, and based on that was able to determine how to treat them and how to follow them afterwards. So basically, you will end up needing tissue biopsy at points. It is recommended by ATS if you don't have, if it's a non-IPF diagnosis, you should get a lavage. So a BAL, it's minimally invasive, cost-effective. It is mainly done to rule out other causes. If you have changes on your scan, you want to make sure there's no infection. It may not be the most, highly diagnostic tool for an ILD, but it'll help you, give you an idea if you're suspecting something to kind of guide you through your differential as to what to expect. Certain definitely pathognomonic features of the BAL is that, you get milky turbid white fluid, it is PAP. If you get sequential progressively red, it is diffuse alveolar hemorrhage, but it does have a role in your arsenal. Next, you would do endobronchial biopsies. So you're getting bronchial mucosa, you're not getting parenchymal tissue, which is where most of the ILDs live. But you do have certain types of ILDs, like granulomatous diseases, that actually have changes on the bronchial mucosa, and you're able to diagnose sarcoid in this way. So it is recommended in those cases. Now we've moved to transbronchial, which is your next step in your biopsying journey. It is limited, small size, there's a lot of crush artifacts, so diagnostic yield still isn't that great, 20 to 30% in most published literature. Certain ILDs may have a higher incident to be diagnosed from transbronchial biopsies, but really it won't be the best bang for your buck. So you got to kind of consider what else to do. EBUS. EBUS has a role, but it mainly has a role in specific ILDs, namely the ones that have mediastinal lymphadenopathy if you're looking at sarcoid again, and it also rules out your differential such as malignancy. Radial EBUS kind of like assists you in guiding where you're going to go, but really on its own, it's just an assistance tool. Robotic bronchoscopy, unfortunately, robots have no place in ILD. They have very limited place, I should say. As you saw from Chenchen's presentation, that, nodules, great. But for ILDs, really, they're not as helpful. So our two major things are cryobiopsy and surgical lung biopsy. So cryobiopsy. Histological yield is about 80%. It goes up with 3 or more samples, which is part of the recommendations. The study that put kind of cryobiopsies more into the mainstream of things was the cold ice study that was published in Lancet in 2021. It wanted to establish the diagnostic accuracy compared to the gold standard, which is surgical lung biopsy. So they had patients that were coming in, they had sequential both a cryobiopsy followed by a wedge, and then they compared the pathology. There was 70% agreement between the two of them, and this actually went up to 76% after the MDT team discussions. There was a definite, if it was high or definitive diagnosis with high confidence, then you got 90% agreement. And, in cases of low confidence, the surgical biopsy actually helped reclassify 23%. So this is the outline of this table. And then I wanted to mention that it was also good to diagnose different ILDs, not just specific ones, so it is very helpful. Comparing the two, so surgical lung biopsy, gold standard, diagnostic yield up to 93%, and some reports it's actually 95%. The issue is not everybody can tolerate, not everybody is a surgical candidate. I have this bolded. They need to be able to tolerate single lung ventilation. Sometimes pulmonologists are not familiar with what goes into single lung ventilation when doing a wedge biopsy, and they end up referring someone that's acutely sick at the hospital with high oxygen requirements. You drop their lung to do a biopsy, they really will not make it well afterwards, and they end up coming to me as a crash consult for transplant. So really assess your patient before sending them for that surgical lung biopsy. There's a high complication rate, there is a procedural mortality rate, and so the alternative, which is cryobiopsy, may look a little bit more attractive, but we're going to talk about that as well. So it does have, like I said, a good histopathological diagnostic yield. It matters where you do it. Centers of excellence have a higher yield. Centers of excellence are 70 plus cases. You have to have institutionalized protocols for that, and like we said, comparable histopathological yield, but also a favorable safety outcome. So how to do it is beyond our talk. You can look at this paper at CHEST that tells you exactly how to perform a cryobiopsy. So European Respiratory Guidelines in 2022, they shifted their recommendation to suggest that a cryobiopsy should be done in patients also that are considered eligible for surgical. It should be done in patients that are considered or suggested in patients that are not surgical candidates. And the surgical biopsy should be an add-on afterwards if there is no alternative information that is found with the cryobiopsy. And they did not make any recommendation either whether if you don't get an answer, should you redo your cryo before trying a surgical biopsy or not. Contraindications, rapid clinical decline, ILD exacerbation. You've missed the chance to biopsy them if they're in the hospital sick. You got to figure it out without the biopsy. If they have pulmonary hypertension, they don't do well. If they have very bad lung function, very low, severe PFTs, then probably this point in life they're beyond the tissue diagnosis to establish what you're going to do next. And then if they're unstable for anesthesia and can't have a large ET tube. Complications, we've mentioned them, pneumothorax bleeding, and then there is a 0.6 mortality, 32-day mortality risk. So two additional tools that help you in your arsenal are the genomic classifier and Hsia. I'm not aware of any other ones, so if anybody else knows anything, please let me know. But this is from Veracyte. It is a clinically validated molecular diagnostic test. It sequences from messenger RNA about 190 genes that are part of the UIP diagnosis of IPF. It is specific and sensitive with very good numbers based on 2 validation studies. And it is used to complement your clinical decision and your imaging. And the way it goes is that you would do transbronchial biopsies and use that, send that out to get the Hsia testing to see. So it has been looked at in conjunction with cryobiopsy as well. And it does show that this is a study that was published actually in CHEST last year, 2024, where they had patients come in, do both cryobiopsy and Hsia, and end up having a 60% agreement between both of them. In cases where they had an indeterminate cryobiopsy, they had a 21% plus chance of a positive Hsia test that helped guide them. It reduces the likelihood to wait and follow up without treatment. It increased the chances of using antifibrotics, so it was pretty positive. It's a kit, you get it, you do your transbronchial biopsies from 2 lobes, 3 to 5 pieces, you send it out, and you get an answer within 14 days. Another thing that I would like to mention here as a tool is confocal laser endomicroscopy. It is sometimes also referred to as fibered confocal fluorescent microscopy. This is something that has moved on to us from our colleagues in GI. So it's high-resolution imaging that is providing immediate feedback during the time of your procedure. It goes off of elastin fibers. It is a laser, a 488 nanometer rapid laser. It comes out of a 1.4 millimeter probe. More specific details next to that line for those of you interested. It was utilized in lungs by
Philberville, which I am hoping I pronounced her name right, in 2007. And basically, they're analyzed via utilizing a Cellvizio software that gives you this image. So this is two. One is the Cellvizio image, one is at the biopsy. You see the pleura, you see the spaces, the alveolar spaces, you see the elastin fibers. And you can look at it in this follow-up space where you see how normal looks. In the middle, you see the area that has a little bit of fibrosis, which would be ideal for biopsying. And then the end side, you see the very fibrotic that probably you're not going to get an answer from biopsying. So this schematic tells you how to progress through these, how to go from your CT into your MDD discussion, getting your surgery, getting your biopsy, getting your tissue, and then discussing. So the take-home message is that when to do a biopsy, when not to do a biopsy, which is also most important. The MDD team is our favorite, and the tools are there to make your life easier. I would like to acknowledge Dr. Jordan Friedman for his assistance, our lung transplant team, and Dr. Ellie Sidougi at Montefiore that has done a lot of work with Cellvizio. Thank you, and I will take any questions.
Thank you, everyone. I want to first thank our panelists, including our fellows, for presenting wonderful presentations. At this point, I would direct you guys to the microphones that are scattered around the room for any questions from the audience. And while we're waiting for that, I'm going to first ask a couple of quick questions. I think one of the challenging things that we have when we're looking at non-malignant disease, especially in things like nodules, we're a lot of times dependent upon data that is directed towards malignancy. So we're almost looking at, you're sort of sifting through the tea leaves to look at all the negative data and trying to figure out what was diagnostic, what was non-diagnostic. Do you utilize anything beyond biopsy tools, the different biopsy tools that you mentioned, culture from saline BAL? Do you utilize anything else like cell-free DNA testing or anything else to try to increase that yield? And who would you utilize that in if you happen to use that tool? Because it's very expensive.
We don't do that in our practice. Going over some literature, there are some suggestions, but what I got out of was, it was not yet well validated. But I would be interested in knowing what other people think here.
Yeah, sure. I feel like with the non-malignant disease, as you pointed out, David, it's really tricky just because you will never be 100% sure that this is definitely benign and it's definitely not malignant. I feel like it's pretty hard to reach that conclusion. So definitely I feel like it will be a sort of like, I almost feel like it's more of a individual-based decision, especially considering what the patient's presentations will be, your clinic suspicion for what kind of disease this would be. For example, if you're in a fungal endemic area where you want to combine your serum testing and other non-invasive testing, like from BAL, like you pointed out, those testing to help you to get to the diagnosis. And for sarcoid, we sort of like touched on that. And then even for like the genomic testing that's available nowadays, I feel like I couldn't really find one that's like perfect for benign disease per se, but sometimes I kind of like see it in the way around. For example, for Percepta, then if it's in the very low risk range, I use that as my assist to diagnose a benign disease. So like you said, a very complicated process. I feel like there is no magic pill to tell you or magic wand to tell you this is definitely benign. You just got to have more patience with your patients and follow up with them.
I just have one comment to add on cell-free DNA. I use it in our lung transplant population for post-transplant following for rejection in conjunction with biopsies, but we do not have any that is being utilized for any of the ILD.
I do want to add that cultures, yes, for sure. If especially unless I have a rose on site who told me that, okay, this is definitely non-small cell. Generally in the workflow, sending a culture, even a tissue culture, if I am intermediate risk nodules, right, that is definitely on the workflow. So we do routinely send lavage or tissue culture even to check that.
Perfect, thank you. Go ahead with your question.
Hi. Hi, my name's Dan Zhang. I'm also from Montefiore. I had a question. I wanted to hear your thoughts on the use of cryobiopsy when infectious disease is considered. There's a theoretical risk that the freezing could lower the culture sensitivity. Do you consider that when choosing the order or modality of biopsy tools?
Thank you for the question. That's actually a really interesting topic. The other panelists, please correct me if I'm wrong. I don't think I've seen any specific data on cryobiopsy and then the yield for culture. I have not read on that, honestly. But clinically, the way that I do it is that, again, it goes back to your clinic suspicion of infection. And again, like what Abesh was just mentioning, if your Rose was suggesting, we're not seeing any malignant cells. It's just, inflammation cells, acute or chronic, however they call it on your own site. If that's the case, usually what I do is I put 3 different cups. Always, it's going to be lab dependent. Our lab is very unique about how they want things to be done. So what I have done is 3 cups. 1 pass of TBNA for bacteria, 1 pass for AFB, 1 pass for culture, for fungal culture. And sometimes if I feel like that pass does not really give me a whole lot of tissue, I do additional pass for TBNA. And then I also put another 3 different cups for my cryobiopsy, and then I take my cryobiopsy and put them in different cups for bacteria, AFB, and fungal. I think Ara's paper actually pointed out with forceps biopsy, it does double your diagnostic yield when you combine that with FNA. So I do feel like if you send more tissue culture to your lab, there is a higher chance for them to catch something. In terms of the risk of cryo killing the bacteria, it's a theoretical risk for sure, but I've also certainly seen that my cryobiopsy has grown something from it. So I cannot really tell you if you should or should not send for cryobiopsy, but from a clinical practice standpoint, I feel like I've shined away from forceps biopsy just because cryobiopsy is so easy to perform. So that's been my experience. I'll defer to the other panelists and see what their experience has been.
Yeah, I agree. Just anecdotally, last week we had a case which we did a cryo touch probe, and the cytopathologist called 3 hours after that they saw AFB bacilli on that slide. So I'm not sure if the freezing would kill. I'm not sure if but maybe that's an interesting question though.
It sounds like you need to do a study on this and get back to us in
Yeah,
a year.
it's a great study.
We'll have to do more forceps, I guess.
I know we're running up against the hour, but if you have a quick question, we'll slide it in.
Actually, I don't have a question. I have a comment. I'm Chenchen from Mayo Clinic, Arizona. So we recently have been doing a study that is comparing these diagnostic yield of these serology plus the fungal flip sign in these cocci endemic area. So basically, we are combining these 2 tools and see the possible predictive value. Actually, that achieved to 83%, which is pretty good. So we are looking for if this serial multimodality can help us to avoid that biopsy. So actually, that is pretty good. And the abstract is accepted at the CHEST, so to be presented.
Congratulations.
We're looking forward to it. Definitely want to thank everyone for your attendance and participation, to our panelists, to our fellows, for joining us. So thank you for coming, and I hope you enjoy the rest of the meeting.